Chapter 11: Childhood and Neurodevelopment Disorders. Up to 20% of the children and adolescents in the United States suffer from a major mental illness that causes significant impairment. These impairments result in disruption to normal patterns of their childhood developmental milestones. These barriers can also result in assessing, diagnosing, and treating young people that much harder. These barriers to treatment include things like clinicians and parents often waiting to see whether symptoms are the result of a developmental lag or trauma response that will eventually correct itself. Unfortunately, this wait-and-see approach means that crucial early interventions may be delayed. While this method may be successful for some children, giving them a little more time to catch up, for others it means that they have now had a major delay in receiving the treatment that they need. Many of the risk factors in this age group will be related to that nature versus nurture phenomenon we talked about in week 1. For the nature part, the biological factors such as genetic predisposition and neurobiological makeup. Other things like cognitive factors such as temperament and resilience. In this case, temperament refers to the overall mood, attitude, and behavior that a child habitually uses to cope with the demands and expectations of the environment. On the other hand, resilience is the capability to recover from difficulties. Just like with adults, some kids are much more resilient. They're much more able to handle stress and bounce back from difficult situations than others. On the other side, that nature side, would be environmental factors such as adverse childhood experiences. Everyone's childhood was different, and some people had a much more difficult childhood than others. And adding to these difficult childhoods would include abuse, such as emotional, physical, sexual, neglect, and household challenges such as having a parent with mental illness, spousal abuse, or substance abuse in the house. Neglect is unfortunately the most prevalent form of abuse in the United States. In our first case study, Mimi, 13, is the child of a single mother who suffers from post-traumatic stress disorder from growing up severely abused herself. This has also made her agoraphobic. Mimi's mother is unemployable because of her emotional instability. Mimi's mother does love her, but often keeps her out of school to take care of her. Despite all this, Mimi, who loves her mother, develops normally. You hear the term resilience used. What are some characteristics this child has? And in this case, resilient characteristics pertain to her ability to change in her environment, ability to form nurturing relationships with other adults, even when her parent is not available, her ability to distance herself from emotional chaos, good at social intelligence and problem-solving skills, along with an ability to perceive a long-term future. And for our first audience response question, Mimi's mother is not abusive or neglectful, but she does put her child at some risk by being overly controlling and keeping her a bit too close, largely out of worry or fear. Which of the following is the most prevalent cause of child abuse? Would that be A, physical abuse, B, sexual abuse, C, verbal abuse, or D, neglect? And again, neglect is the most prevalent form of child abuse in the United States. According to the U.S. Department of Health and Human Services, 75% of all abuse victims were neglected, 17% were physically abused, and about 8% were sexually abused. Although neglect has a much higher incidence rate than physical or sexual abuse, research into its effects on children's mental health has been studied less. Assessment and data collection can be much more difficult in this age group. Methods of data collection include interviewing, screening, testing both neurological, psychological, and intelligence, along with observing and interacting with the child or adolescent. In addition to the patient, ideally data will be taken from multiple sources, including parents, teachers, and other caregivers. Parents and teachers can complete structured questionnaires and behavior checklists. A family diagram called a genogram can also be used to illustrate family composition, history, and relationships to identify any other areas where the patient could be at a greater risk of developing problems. General interventions for children and adolescents could take a lot of different forms. It could be behavioral interventions, bibliotherapy, involving the use of literature to help the child express feelings in a supportive environment, gain insight into their own feelings and behavior, and learn new ways to cope. They could also try strategies such as play therapy, expressive arts therapy, journaling, music therapy, or family interventions. And last but not least, disruptive behavior management could be another technique used. These are techniques selected to the principle of least restrictive and include strategies such as timeout, quiet room, or in most severe cases, seclusion and restraint. Again, that disruptive behavior management is on the principle of the least restrictive first. That seclusion and restraint would be an absolute last resort for only the most severe cases. At the same time, timeout, quiet rooms, other disruptive behavior management strategies are necessary. Helps to set boundaries, helps to set consequences for going outside of those boundaries, and provides the child with the structure that they need to grow and progress. For treatment modalities, one would be that biological treatment, that pharmacotherapy. And this is going to be a multimodal approach. We're going to use medications, but it's also going to be the inclusion of medication best when combined with psychotherapy. And we're also going to have a lot of the different psychological therapies used, everything from cognitive behavioral therapies, replacing negative, self-defeating thoughts with more realistic and accurate appraisals, to improving their functioning. One strategy used often with this age group is group therapy. For younger children, you could use play and help them explore new ideas. For grade school children, you would combine play along with learning, skills, and talk. And finally, for the oldest adolescents, helping with them working with identifying emotions, modifying responses, learning skills and talking, focusing largely on peer relationships and addressing their specific problems. Moving on to neurodevelopment disorders. Neurodevelopment disorders can take many different forms: communication disorders, motor disorders, tic disorders, specific learning disorders, and intellectual disabilities. For our second case study, Victor, 5, will soon be starting kindergarten, and his dad, a single father, is very anxious. I have no idea how Victor is going to make it in school. He's completely out of control. I have trouble getting him to calm down. When he was little, I was kind of proud of how active he was, running from one thing to the next. I took it as a sign of curiosity and intelligence. But as he's gotten older, he's still like that, only he can't calm down and sit still for anything, like the other kids his age. Something's got to change. And this can be very common in that age group. It sounds like we're starting to go towards ADHD. We'll start with communication disorders and language disorders. And these involve difficulties in obtaining and using language due to deficits in the production or comprehension of language. They can take two different forms: expressive, meaning the child's unable to express ideas, or receptive, meaning they're unable to receive and process new ideas. They can also take the form of speech sound disorders, where the child has problems making sounds, enunciating, or forming those words. Other communication disorders could be childhood onset fluency disorder or stuttering. Also, social communication disorder. This disorder would involve problems using both verbal and nonverbal means for interacting socially with others. Moving on to motor disorders, we discuss developmental coordination disorder, and this involves impairment in motor skills development, coordination below the child's developmental age, and problems that interfere with academic achievement or activities of daily living. For developmental coordination disorders, symptoms include delayed sitting or walking, or difficulty jumping or performing tasks such as tying shoelaces. Serious impairments in skills development or coordination are usually obvious. Children with less severe impairments may be less noticeable, and they may be identified by their avoidance of certain tasks or abilities. They know that they are unable to perform that task the same as others, so they may avoid it. Another one would be stereotypic movement disorder. This would involve repetitive, purposeless movements for 4 weeks or more, such as hand waving, rocking, head banging, nail biting, or teeth grinding. Other motor disorders would involve tic disorders, and these are sudden, non-rhythmic, and rapid motor movements or vocalizations. At the lowest end would be provisional tic disorder. This involves single or multiple motor and or vocal tics for less than 1 year. Next up the line would be persistent motor or vocal tic disorder. These are single or multiple motor or vocal tics, but not both for more than 1 year. And finally, at your most severe end would be Tourette's disorder, involving multiple motor tics and or at least one vocal tic for more than 1 year. For treating tic disorders would involve a multitude of strategies. For behavioral techniques, we'd work with comprehensive behavioral interventions for tics, CBITs. It's a habit-reversing technique that works by helping the patient become aware of the building up of a tic and urge them then using a muscular response in competition to make that tic incompatible, helping them focus elsewhere. Other strategies would be medications such as antipsychotics or even The most invasive would be deep brain stimulation. This is used when more conservative treatments have failed. A fine wire is threaded into affected parts of the brain and connected to a small device implanted under the collarbone. This device then delivers an electrical impulse. Users of deep brain stimulation can turn the device on to control a tic or shut it off when they go to sleep. Moving on to specific learning disorders, it's said that 1 in 5 children face a learning disability, and the long-term outcomes for these children with learning disabilities can vary. Some can be overcome much easier than others. These learning disorders can take many different forms, such as dyslexia with reading, dyscalculia with math, or dysgraphia with written expression. Intellectual development disorder can involve deficits in intellectual functioning, social functioning, daily functioning, and in intellectual functioning, these deficits involve reasoning, problem solving, planning, judgment, abstract thinking, and an ability to comprehend at the same level as their peers in their age group. Social functioning would involve impaired communication and language, interpreting and acting on social cues, and regulating emotions. And finally, daily function would involve practical aspects of their daily life that are impacted by the deficit in managing age-appropriate activities, such as functioning at school or work and performing self-care. Our assessment guidelines would involve assessing for delays and assessing for signs of potential neglect and abuse. And again, it comes up a lot in ATI and NCLEX. Your 2 mandatory forms of abuse to report are child and elder. If there is any hint of child abuse or elder abuse, it is legally mandatory for you to report that. For our nursing diagnoses and resulting outcomes, they can vary wildly and are dependent on the assessment findings and differ wildly from one disorder to the next, and also from patient to patient. For this reason, our treatment plans should be individualized and realistic. Although the care plan is developed for the child, family members and caregivers, and school personnel should be included in the process. Supportive education should be ongoing regarding the scope and nature of the illness, social and practical deficits, and realistic assessment of the child's potential and strategies to overcome them. Autism spectrum disorder. These are persistent deficits in social communication and social interaction across multiple contexts. Everything from social-emotional reciprocity, nonverbal communicative behaviors used for social interaction, and developing, maintaining, and understanding relationships. These restricted, repetitive patterns of behavior, interests, and activities can include stereotyped or repetitive motor movements, use of objects or speech, such as simple motor stereotypes, lining up toys or flipping objects, echolalia, meaning repeating and echoing back your words to you, and other idiosyncratic phrases. Other manifestations could be an insistence on sameness, excessive adherence to routines, or ritualized patterns of verbal or nonverbal behavior, such as extreme distress at small changes, difficulty with transitions, rigid thinking patterns, greeting rituals, and a need to take the same route or eat the same foods every single day. For autism spectrum disorders, symptoms must be present in the early developmental period. Symptoms together limit and impair everyday functioning and are not better explained by an intellectual disability. The DSM-5 classifies autism spectrum disorder in 3 levels, depending on the degree of assistance and support that the individual requires. At level 1, they would require support. At level 2, they would require substantial support, and at level 3, the highest level, they require extremely substantial support. Our goals for autism spectrum disorder involve the early intervention programs. We want to begin treatment as early as we can, involving behavior management with reward systems and family support. The outcomes for these social interaction skills include cooperating with others, exhibiting cooperation, and exhibiting sensitivity to others. Improvement in communication skills outcomes, including accurately interpreting messages and accurately exchanging messages. Family normalization is associated with adapting to the challenges of living with a child with autism spectrum disorder. Pharmacotherapy would also be used for this disorder. Often the first line is going to be second-generation antipsychotics such as risperidone or Abilify, and they have FDA approval for treating children with autism-associated agitation. Stimulants are often also used to treat a comorbidity of ADHD symptoms and may be used to target the hyperactivity, impulsivity, and inattention. Another option would be selective serotonin reuptake inhibitors, SSRIs. And these are most often used in the category in patients with autism. They improve the mood and reduce anxiety, which provides the patient with a higher degree of tolerance for new situations. Audience response question. A patient is scheduled for DBS, deep brain stimulation. Which of these disorders is most likely to improve from such treatment if all else has failed? Would that be A, a tic disorder, B, autism spectrum disorder, C, social communication disorder, or D, developmental coordination disorder? That answer is going to be A, tic disorders. It's a sort of, and again, these DBS, deep brain stimulation, is a sort of pacemaker for the brain, and it's used when those more conservative treatments have failed in the case of tic disorders. One of your most commonly diagnosed childhood disorders would be attention deficit hyperactivity disorder, and this involves an inappropriate degree of inattention, impulsivity, and hyperactivity. It could also be an absence of hyperactivity. Diagnosis is still ADHD, but further classified as primarily inattentive types. ADHD, we would need to be assessing their level of physical activity, their attention span, and their talkativeness. Also be assessing their social skills, any other comorbidities, and symptoms present in at least 2 settings. The outcomes need to be focused on what is appropriate for the child and target their hyperactivity, their impulse self-control, make sure their freedom from injury, improve social relationships, and the development of self-identity and self-esteem, positive coping skills, and improved family functioning. Continuing with our case study, Victor has started kindergarten and still exhibits the same problems his father expressed frustrations with earlier. His hyperactivity in particular, and his inability to listen when his dad tries to correct or slow him down. Victor is assessed today for the following: level of physical activity, attention span, talkativeness, social skills, and comorbidities. For the implementation, we're going to be looking at individual, group, and family therapy as another means of treatment, and work with managing those disruptive behaviors, such as through a behavioral contract or collaborative and proactive solutions. This would involve a therapeutic intervention used with parents and children designed to help both identify and define problematic behaviors, specific triggers, and develop a collaborative method for creating mutually agreeable solutions to a specific solution or trigger. In planned ignoring, this is when behaviors are determined by staff to be attention-seeking and not dangerous. They must be ignored. Additional interventions may be used in conjunction, such as positive reinforcement for on-task actions. And finally, the use of signals or gestures. And this would be the use of a word, a gesture, or eye contact to remind the child to use self-control. We could also try a variety of psychosocial interventions, such as redirection. This would be a technique used after an undesirable or inappropriate behavior to engage or re-engage an individual in an appropriate activity. It may involve the use of verbal directives, such as setting firm limits, gestures, or physical prompts. We could also try clarification as intervention, meaning breaking down a problem situation that a child experiences and can't help the child understand the situation, the roles of others, and his or her own motivation for the behavior. This can be done verbally or using worksheets, depending on the age and functional ability of the child. And finally, restructuring. This would be changing an activity in a way that will decrease the stimulation or frustration. For a diagnosis of just ADHD, we would focus on the symptom patterns and their severity. Moving up to the more severe levels, such as ADHD inattentive type or ADHD hyperactivity impulsive type, or any combination of these types, we'd focus on academic performance, activities of daily living, social relationships, and their own personal perception of the disease. Victor is diagnosed with ADHD after being assessed both at home and at school. To begin with, a psychiatric mental health nurse worked with Victor to help him change his patterns of misconduct, working with Victor's father as well to help him develop internal controls, and to help them both improve coping and support. Victor expresses delight over a few CBT games aimed at developing problem-solving skills and conflict resolution. The use of medications are discussed as a possibility. Which statement demonstrates that Victor's dad understands the diagnosis of ADHD? Would that be A, Victor will never be able to graduate or go to college, but may be able to learn a vocational skill? B, Victor's performance will improve in a structured setting that provides rewards for appropriate behavior? C, nothing is wrong with Victor. The school hasn't provided a quality education and classroom setting. Or D, Victor's just going through a stage. This problem will go away on its own. And that answer here is going to be B. Victor's performance will improve in a structured setting that provides rewards for appropriate behavior. There's many people out there living with ADHD who have gone on to live full functional lives, live successful lives. It can just be a slightly more difficult. He's going to have some hurdles and some things to work through as he manages ADHD. There's going to be a wide array of treatment modalities that could be used for this condition, beginning with pharmacotherapy. There's a lot of different medications on the market to increase attention and task-directed behavior, such as Ritalin, Adderall, Vyvanse even. And again, remember back to our medication chapter, when we talked about these stimulant ADHD meds especially, make sure that they're always given in the morning and make sure that the patient has eaten first, because these are a very strong stimulant that can remove the patient's appetite. We don't want them having sleep disturbances. We want it first thing in the morning, but making sure that they've had breakfast. Another audience response question: which child would be most difficult to diagnose for a neurodevelopment disorder? Would that be A, 3 years old, B, 5 years old, C, 8 years old, or D, 12 years old? And yes, that answer is going to be A, 3 years old. Generally, the younger the child, the more difficult it is to diagnose their issues. They're just not as developed yet, and it's not until they get older that a lot of these conditions will begin to manifest more and more. And our final question: a 4-year-old frequently lashes out in anger at adults and other children. This child's style of behavior is an aspect of A, neurobiology, B, temperament, C, resilience, or D, culture. And that answer here is going to be B, temperament. Again, temperament is the style of behavior a child habitually uses to cope with the demands and expectations of their environment. Anyway, that's all we've got for this chapter. I'll see you in the next slides.